My name is Julie Barron, and I'm the International Medical Director at Exact Sciences. And tonight we have the pleasure of having a great faculty to talk in particular about the RxPONDER trial results that were reported at San Antonio only a couple of weeks ago. And we will discuss what is this changing to clinical practice. To this end, tonight we have with us really renowned faculty with Professor Stephen Chia from Canada, medical oncologist, who importantly is in the steering committee of the RxPONDER study. He is professor of medicine at the University of British Columbia, also co-chair of the Canadian Cancer Trial Group, specifically for breast disease. Dr. Mark Verrill from the UK is consultant medical oncologist for breast cancer and sarcoma in Newcastle, in Hospital Foundation from the NHS Trust, and head of the Department of Medical Oncology in Newcastle. Also lead clinicians for a number of studies in breast cancer in particular, and in the North of England Cancer Network. Also a member of the National Cancer Research Institute. So with no further ado, I would like to start our webinar tonight, invite Dr. Mark Verrill to give us a bit of an introduction before we hear Stephen about RxPONDER in particular, open for further discussion.
Thank you, Julie, and thank you to Exact Science for the kind invitation to join this meeting. So what I'd like to do is just do a little bit of scene setting for the main content of this evening's webinar, which is Stephen Chia's presentation of the RxPONDER data. And the question that I think we always ask when we're at meetings is, what are we going to do that will change immediately or very quickly our clinical practice? So I'll cover some of the practical implications at the end, and just a little bit of background for where we are now. These are my disclosures. So we're all familiar that with early breast cancer, our aim is to eradicate the cancer while avoiding overtreatment. But I think it's a shame, or it's a reflection of the way we do clinical trials, that in breast cancer we've tended to add things. So we went from no treatment to adding endocrine therapies, and then chemotherapy with non-anthracycline regimens, and then anthracyclines and taxanes. And we keep adding in drugs without really any good way of knowing what we should be adding in whom. But as time has moved on, targeting tumour biology has become the standard approach, and we have much greater understanding than we did even 10 years ago about what's driving cancer. And now all of our drug development really focuses on patients, samples, identification of biomarkers, understanding of the molecular pathways that are driving cancer growth, and as much as we can, individualizing care based on those biomarkers. And there's an expectation that any new systemic anti-cancer therapy will have an appropriate companion diagnostic. And probably the most obvious example in breast cancer is the use of anti-HER2 drugs in patients who have HER2 overexpressing breast cancers. So what about chemotherapy? Well, those of you who are keen biologists on the left will recognize Streptomyces pusetius. That was a soil microbe dug up from around the Castel del Monte in Italy in the early 1960s, and was initially going to be developed as an antibiotic, an antimicrobial antibiotic, but was too toxic to be used. But it was shown in cell systems to kill cancer cells. And on the right, you have Taxus brevifolia. And having grown up in the southeast of England, I still remember seeing my neighbours sweeping up their yew leaves and putting them into bags and sending them to France to make docetaxel. So really very humble origins. And as I've already suggested, we picked up cancer drugs not because we understood why they were working, but we understood that they had an anti-cancer effect because we tested them against cancer in various different in vitro assays. This is an MTT assay. So having worked out that we could kill cancer cells with chemotherapy, we got into this almost ideal or idealizing of chemotherapy as something that should be given to everybody. So this is winding the clock back 20 years and looking at the guidance around the turn of the millennium. And the working supposition was that adjuvant chemotherapy would reduce recurrence in estrogen receptor positive node negative breast cancer, as well as all the other cancer types. Of course, back then we weren't even testing for HER2 in early breast cancer. And that adjuvant chemotherapy should be recommended to the majority of women with localized breast cancer, more or less regardless of anything, be it lymph nodes, menopausal status, or receptor status. And you'll all be familiar with this curve, the primary endpoint curve from the TAILOR-X study, where the Oncotype DX recurrence score was applied to estrogen receptor positive, HER2 negative, node negative patients with Oncotype scores in the range 11 to 25 on the supposition that those with scores that of less than 11 didn't require chemotherapy. And there was a cliff edge at 25 where chemotherapy had a large benefit. And I'll be interested to hear Stephen's comments about the cutoff. But as you can see in this headline analysis, it's impossible to put a cigarette paper between the survival curves for those patients who did and did not receive adjuvant chemotherapy. This is a lymph node. You can see the lymphoid cells here with breast cancer cells invading it. And it seems that as soon as we see cancer in a lymph node, we throw away our considerations of tumor biology. We have this knee-jerk reaction that chemotherapy must be given. And in the UK, for instance, our funding for oncotype testing does not permit NICE funded oncotype assays in patients with node-positive disease on the basis that we should be offering all of those patients chemotherapy. It's not a very biological, it's not a very modern way of looking at things. Just a reminder of the modest gains that we get with each of the iterations of chemotherapy, an additional 4% with CMF versus nothing, another 4% with the anthracyclines, 5% with the taxanes. But this is a relatively high-risk group, and all of these patients are doing much worse than we'd expect patients to do in 2020 and 2021. Limited lymph node positivity is not a cliff edge. So we've got the TAILOR-X population here with no nodes. We've got the population down here with masses of lymph nodes where we've clearly got to do something. We're going to throw the kitchen sink at the patient. And even if we have a modest hazard ratio favoring chemotherapy, that's going to turn into a large absolute benefit. But there's a limited value for more modest proportional gains in the group of patients with only a handful of involved lymph nodes. This is the output from the SWOG 8814 study of chemotherapy versus not in node positive patients banded by their oncotype recurrence score, and was essentially the hypothesis generator for the RxPONDER study. So we can see here on the left, in the patients with what used to be known as a low recurrence score of 0 to 17, there was no significant chemotherapy benefit. In the group with a score of 18 to 30, again, there was no significant chemotherapy benefit. And I think if your starting position was that chemotherapy is a group of filthy poisons and best avoided, it wouldn't persuade you to give chemotherapy. Unfortunately, by the time this analysis was published in 2010, the norm was to give chemotherapy to everybody with node-positive disease. And clearly this trial doesn't have the statistical power to tell us that it's a bad thing. But it's very clear that in the group of patients with what used to be the cutoff for a high recurrence score of 31, there's a large absolute benefit from chemotherapy, a big advantage, and you would undoubtedly offer treatment to patients who fell in that group. I just want to give you a little case history. This is a lady I saw just before, or just in November, who presented in August 2020, just before her 49th birthday. She thought she had another cyst, having had benign cysts in 2018. She had uncertain menopausal status. She had a Mirena progestogen-eluting coil in situ that had been there for, I think, 3 years, and had a pea-sized lump in her left breast that was mammographically occult, 6 millimeters on ultrasound, not felt to be particularly suspicious, but was biopsied. And it was somewhat of a surprise when she was found to have an invasive ductal carcinoma of no special type, grade 2, ER positive 7 out of 8 using the all-red score, PR positive 3 out of 8, and HER2 negative. She had an MRI scan that showed a 15mm lesion, and there was a very large area of non-mass enhancement, taking the total size to 70mm, with a second biopsy of the non-mass enhancement confirming DCIS. The axilla looked normal on all of the imaging modalities, and she was advised mastectomy, having an oncoplastic skin and nipple sparing mastectomy with immediate reconstruction and sentinel lymph node biopsy. The final pathology was of an 18mm grade 2 ductal carcinoma in a much larger field of DCIS, with a single 6mm macrometastasis without extracapsular spread in the 5 axillary nodes that were sampled, 1 sentinel and 4 non-sentinel nodes. And she was referred in knee-jerk fashion for chemotherapy. We have been and are running an oncotype decision support study for patients with N1 disease. And in late November, when I first saw her, she consented to the study and went away for the test to be processed, in the knowledge that in the next couple of weeks, I would be attending the San Antonio Breast Cancer Symposium, when we knew the results of the RxPONDER study would be published or presented, and that we may have some more information to bring to the party when I return from my Zoom room to give her the results of the test. And at that point, I'd like to hand over to Stephen.
Thank you, Mark. Good afternoon and good evening, everybody. I'm just going to share my screen and go ahead and present data, the actual data that was presented at the San Antonio Symposium in regards to the RxPONDER trial. Again, also want to thank Exact Sciences for putting on this webinar. So this is the first presentation of SWOG S1007. This, in fact, was an international collaboration between the US intergroups, Canada's Canadian Cancer Trials Group, as well as sites in Europe, including France, Spain, as well as in Asia. I do have some disclosures to myself or to my institution for conducting the research studies, and I was fortunate enough to be involved as a steering committee member and author on this study. So as a reminder to everybody in regards to the actual randomization, these were both pre- and postmenopausal women that was estrogen receptor positive by ASCO-CAP guidelines, which is 1% or greater as locally assessed. Patients had to have 1 to 3 lymph nodes. After about half the patients were enrolled, only macrometastases were involved, and again, up to a maximal of 3 lymph nodes involved. Patients had to be medically fit to receive a different range of chemotherapy options, which was TC times 4 all the way to dose dense ACT. What was not permissible was AC alone or CMF. Patients could have received only a sentinel procedure, not an axillary node dissection. The sample size was 5,000 patients, and randomization was to the standard arm, which is actually chemotherapy followed by endocrine therapy, as Mark has nicely outlined over history. That is the standard consideration in node-positive breast cancer. And then the experimental arm, in fact, was endocrine therapy only. So this was a de-escalation type study. It's important to recognize the stratification factors. That recurrence score was 0 to 13 in one bin, 14 to 25. Anybody with a score of 26 or higher was excluded from study. They were recommended to receive chemotherapy. They were also stratified for menopausal status, and that is important as we look at the statistical plan as to what happens if the primary endpoint was not met. The primary objective was to actually determine if the effect of chemotherapy on invasive disease-free survival based on patients with 1 to 3 lymph nodes and a recurrence score of less than 25 or equal to was dependent on the recurrence score. In other words, the chemotherapy benefit with an increase in recurrence score as an intent to treat analysis. So this is meant to really look for predictive effects for the continuous recurrence score based on chemotherapy and IDFS. If in fact the interaction test was positive, one can conclude recurrence score is predictive on the relative and then absolute benefit of chemotherapy in a score of 0 to 25 in this patient population. If it was not significant, then the next step was to actually look for prognostic effects, no longer a predictive effect, but based on the stratifications of menopausal status. This study had a 5-year overall IDFS of 92.4% as your baseline with an 86% power to detect this. So it's actually important to recognize that this study was not necessarily powered like the Taylor-X study. That actually was powered as a non-inferiority study to omit chemotherapy. This study was powered differently. This was powered to actually look for prediction based on the continuous score of the recurrence score. So we actually were a bit surprised that at the third interim analysis that we would actually see data presented, because at the third interim analysis, about half the expected events had occurred. And at that rate, we thought it would be at least another 2 to 3 years. However, the Data Safety Monitoring Committee and the NCI felt, based on the results, that the study should be reported at this time point. So this was actually an interim analysis that then triggered release of the results. We will see data on not just IDFS, but overall survival, and we will actually look at the breakdown of sites of relapse or deaths. At a later point in time, toxicity, patient-reported outcomes, and a more specific Kaplan-Meier analysis for distant disease-free and local disease-free survival will be presented. So a lot of patients were screened, about 9,400 patients, for which most were not ineligible based on recurrence score of 26 or higher. Interestingly, 2,300 patients refused after receiving their recurrence score. So I guess they kind of ran with their score and decided what to do. Sample size of 5,083 patients were then randomized into one-to-one manner to either the control arm of chemo followed by endocrine versus endocrine therapy. It's interesting to note in terms of refusal to adhere to the randomized arm, those that were randomized to endocrine therapy, 4% refused and I guess decided to receive chemotherapy with endocrine therapy. But actually more so, this kind of shows you sort of the mindset of both patients and I think clinicians of trying to reduce treatment. Those that got randomized to chemoendocrine, 7% refused treatment and likely received endocrine treatment alone. Half the patients received a non-anthracycline regimen, and we'll see more of the details of this in the publication. A very common question that will be asked and continue to be asked was, what about if in the endocrine therapy only arm, the premenopausal received ovarian suppression plus endocrine therapy based on SOFT and TEX? Unfortunately, I'm not sure we're going to have power to answer this because 16% of patients in the endocrine therapy only arm received this ovarian function plus endocrine therapy for the premenopausal cohort. So it happens to unfortunately be a minority. It's actually very sobering to remember and to actually, I tell all my patients, there's about a 1 in 1,000 chance of dying if you receive adjuvant chemotherapy, and that's reflected here. 3 patients out of 2,500 died on the chemo and endocrine therapy arm, sepsis, typhus, and liver necrosis. The baseline characteristics were well balanced. You can see about 2/3 was Caucasian, 1/3 were premenopausal. It's almost a 40-60 split of a recurrence score 0 to 13 versus 14-25. Again, that was a stratification factor. Likewise was menopausal status. As we'd expect, about 2/3 present with 1 node and 1/3 present with 2 to 3 nodes. The distribution of grade is a normal distribution, and this is what we typically see, more intermediate grades. It's a bit skewed here to more low grade versus high grade because, again, this is capped at a recurrence score of 25 or lower. So the primary analysis, again, was to see if there was a positive interaction test between recurrence score, chemotherapy, and IDFS. And the answer is there was not. So the hazard ratio of 1.02 was not statistically significant. So recurrence score did not predict the relative benefit of chemotherapy for the primary endpoint of IDFS. The other way of thinking about it is that The benefit of chemotherapy was not smaller with a low recurrence score, nor was it greater with a high recurrence score. And that's important to keep in mind as we try to interpret this within the subgroups that we are looking for. So then, as the pre-planned statistical analysis was, then let's look for an independent prognostic effect. And throwing in the variables, chemotherapy, in fact, led to a better outcome with a hazard ratio of 0.81. Menopausal status did not have an effect on IDFS, but recurrence score was prognostic. So the higher the recurrence score per unit change, hazard ratio of 1.06. So again, those that receive chemotherapy, less likely to have an event. Those with a higher recurrence score, more likely to have an event. Those were prognostic, but throwing 3 variables in does not show a predictive effect. So the Kaplan-Meier curves for the intent to treat population, including both pre and postmenopausal, all nodal status of either 1 node or 2 to 3 nodes, shows that in fact, statistically, there was benefit to chemotherapy for the entire population. Hazard ratio 0.81 with a p-value 0.026. The absolute difference is very modest though, at 1.4%. And I think if this was a chemotherapy study, we would all be struggling to feel if this was worth the benefit for IDFS. In terms of a pre-specified secondary analysis then was chemotherapy benefit different based on menopausal status? And here there was prediction. Menopausal status predicted for chemotherapy benefit, hazard ratio 1.79, a p-value 0.008. So a way to look upon that is graphically is in the postmenopausal group, chemo versus no chemo, the hazard ratio is 0.97. The absolute difference in distance recurrence as the first site was 0.3%. And so I think we would, when you look at the Kaplan-Meier curve on the left, state that there is no benefit to chemotherapy for a recurrence score of 0 to 25 in postmenopausal women. Conversely, in premenopausal women, the hazard ratio 0.54, so almost a 50% reduction in an IDFS event, and the absolute benefit is 5.2%, p-value is less than 0.001. Secondly, then you want to look at what are the events. And so it is broken down. If you look at the postmenopausal, there is a balance of distant, local, regional, non-breast primary, and importantly, death not due to recurrence or second primary. So death due to an unrelated cause is one of the more common events happening, as is non-breast primary, contributing to an IDFS. But importantly, both local, regional, and distance was not much different. Conversely, in premenopausal women, you don't see many deaths due to due to other events. They're relatively low, as well as non-breast primary cancers was relatively low. You get a halvening of a distant event rate here and almost a half of a local regional event rate. So this is what's predominantly driving the IDFS event rate. And overall, the absolute difference in distance recurrence-free survival with about 5 years of median follow-up is 3%. When we look at forest plots, really what's important is to see that the confidence intervals are wide and there's no interaction test positive. And this is a nice illustration of not trying to overinterpret forest plots. So let's look at the premenopausal high grade. In fact, the trend favors endocrine therapy. Low grade favors chemoendocrine, but the interaction test is not significant and the confidence intervals are wide. So this shows you the risk in following into this rabbit hole if you try to overinterpret forest plots that are not powered to do such. Now, how about within the recurrence score cut point? So again, it was stratified to look at a score of 0 to 13 versus 14 to 25. In postmenopausal, the hazard ratio 0.96, 0.98. There's really no difference when you go up in recurrence score for difference. And likewise, and this is going to be an interesting discussion I think that we can have, even with a recurrence score of 0 to 13, the hazard ratio 0.46 is in fact numerically greater than a hazard ratio of 0.57 with a recurrence score of 14 to 25. The absolute difference is 4% roughly with a score of 0 to 13 and 6% of 14 to 25. So at least in my conclusions, you'll see, I really don't think having a recurrence score of 0 to 13 versus 14 to 25 changes my decision-making in terms of recommendation of adjuvant chemotherapy. And likewise, if we break it down into nodes, 1 node versus 2 to 3 nodes, again, no difference for postmenopausal, hazard ratio is 0.9, 1.09. And likewise, there's at least a 5% absolute benefit, even if 1 single node was involved versus 2 to 3 nodes. So again, having more nodes involved versus 1 node doesn't really change my decision-making for the premenopausal. And then here's, I feel, the cincher, and that is in the postmenopausal, there is really no difference in overall survival. But in premenopausal, again, with a median follow-up a little over 5 years, there's already a statistically significant improvement in overall survival, regardless of nodal status, regardless of recurrence score of 0 to 13 versus 14 to 25, in favor of providing chemotherapy. The absolute difference is 1.3, hazard ratio 0.47. So again, the event rate is still pretty low overall. Fortunately, at 5 years, 97 to 98.6% of patients are still alive if they're premenopausal, but that difference of 1.3% is almost a halving of a fatality rate. So the conclusions here at an interim analysis of really about half the events is that the recurrence score, at least from 0 to 25, was prognostic but not predictive of chemotherapy benefit for the entire population. In postmenopausal women with a recurrence score of 0 to 25 and 1 to 3 lymph nodes involved, they did not benefit from adjuvant chemotherapy in any subgroup. In premenopausal, regardless of the range, there was benefit, and it was consistent regardless of 0 to 13 and 14 to 25, and regardless of 1 node versus 2 to 3 nodes. And furthermore, there was a 1.3% absolute benefit in overall survival, which was about a halving of events. You will see further follow-up in future analysis. There is rich quality of life as well as some correlative science. And as I mentioned, there will be future follow-up in terms of overall survival as well, just to see if the curves maintain over time. I wanted just to end with some of my conclusions, is just to remember that this was not powered as a non-inferiority study. Much like, unlike TAILOR-X. However, it really does appear there's limited to no benefit to adjuvant chemotherapy in the postmenopausal cohort, as I mentioned, with a recurrence score of 0 to 25 and 1 to 3 nodes. I do struggle in my clinic, and I have discussions with my colleagues and others, is what is the actual optimal recurrence score cut point to demonstrate benefit for postmenopausal, both in node negative and in 1 to 3 node positives. And I think the way I reflect upon is I have to go back then to the SWOG 8814, as well as the original prospective retrospective analysis of the B18 trial, a B20 trial story, to show that really a score of 31 or higher to me is my decision point at present. And you could argue what's different from 30 versus 31. One of the advantages of the recurrence score is it's a continuous score. And so when you look at the curves, when you hit 25, it's hard to imagine that when they're at 25 and the curves are on top of each other, they're going to separate at 26. At least I practice in a publicly funded healthcare system, much like Mark. It have to show cost effectiveness. I do not believe that it's cost effective, and I think there's limited clinical utility to order an oncotype in my premenopausal 1 to 3 node positives. I do believe, however, there's clinical utility and cost effectiveness in my postmenopausal 1 to 3 nodes, much like we currently do in node negative. I think it's uncertain if we're going to see differential benefit in the premenopausal control arm that received an LHRH and AI, because this is the minority. We may have a discussion, can you do a poor man's oncotype with grade and Chi-67? And I would throw caution to that until correlative studies have been done to demonstrate concordance. I think that when we're making such an important decision for our patients, chemo, no chemo, what is your optimal adjuvant curative regimen, we should go with level 1 evidence. And at present, this would be the oncotype or the recurrence score, at least for my view, for point my postmenopausal in the 1 to 3 nodes. So with that, I do thank you for taking the time to listen to me, and I'm going to pass this back to Mark.
Thank you, Steve. That was great. I'm now going to go back in. And of course, this is our patient that we discussed before. So her numbers came back with a recurrence score of 22. You get quite a lot of additional information. So for those of you who are not that familiar with the node positive score, you get distant recurrence at 9 years with aromatase inhibitor or tamoxifen alone of 18%. That's based on a trial called TransATAC, which was a translational research study led by Mitch Dowsett at the Royal Marsden in London, and looking at patients who were in the ATAC trial, which was the tamoxifen versus anastrozole versus the combination study. And patients see this 18% if you give them the result, and they panic, basically, because I think that represents a much higher risk than we would expect using other data sets. Then you get the group average. This is based on SWOG 8814 that I've showed you before, and it says that chemotherapy benefit for this group cannot be excluded. And then this is SEER registry data of outcomes in patients treated without chemotherapy based on recurrence score results. So if you see here, 0 to 10, 98% survival, breast cancer specific survival at 9 years, 11 to 15, 99%, 16 to 20, 96%, 21 to 25, 93%. So we've got this 9 years, and a very big disconnect between the data that came from this just one study, ATAC, and the real-world evidence from the SEER registry. So I think that's a slightly thorny problem in interpretation of the data. And then you see, as you get to a recurrence score of 26 plus, the figure drops to 84%. So we had a discussion with the Oncotype result, and the options that we thought about were chemotherapy. And if we are giving chemotherapy, now we know that we need chemotherapy, or when we know that we need chemotherapy, I've strayed away from using either an anthracycline or a taxane, and tend to give an anthracycline and taxane combination. And we use FEP-T, which is the French iteration of the anthracycline and taxane combination. And I'll remind you of the subgroup analyses from that showed actually a slightly bigger benefit in postmenopausal women than premenopausal women. We're moving away from that a bit now towards EC, followed by paclitaxel on a 2-weekly schedule, on the basis that there's a lot of noise now around DPD deficiency, and we have to test everybody for it before we give them 5-fluorouracil. So that would be option one. Then on the basis of her uncertain menopausal status, we could have given her 5 years of tamoxifen initially, or potentially tamoxifen plus ovarian suppression, or ovarian suppression and exemestane, as came out of the SOFT and TEXT trials. And just a reminder, I was really pleased that Stephen touched on this. This is the New England Journal paper looking at the combined analysis of the SOFT and TEXT studies. And these were two studies with 5,700 patients who were randomized in the SOFT trial to tamoxifen plus ovarian suppression, or exemestane plus ovarian suppression. And in the TEXT trial, essentially it's the same, except the tamoxifen alone arm has been removed, and you saw tamoxifen plus ovarian suppression versus exemestane plus ovarian suppression. This is the SOFT progression-free survival in the intention to treat population. And as you can see here, first of all of these survival curves are lower than we saw in the TAILOR-X study, albeit with longer follow-up. But you can see a very meaningful numerical difference between tamoxifen alone, tamoxifen plus ovarian suppression, and exemestane plus ovarian suppression, with positive hazard ratios that reached statistical significance. And in the subgroup analyses, which I haven't shown, patients who received chemotherapy derived the greatest absolute benefit from ovarian suppression plus exemestane. So I'm minded to think that at least some of the effect of chemotherapy in the RxPONDER trial is the powerful effect of ovarian suppression in this group of patients. And I think that there are some reasons to favor that argument. I'm not completely sold on it, and I think RxPONDER does actually put us in a position where we're almost compelled to offer chemotherapy. But one of the things that I find most convincing is the lack of any association between recurrence score and chemotherapy benefit. And there are two explanations to that. Either chemotherapy is not acting biocytotoxic, or of course, there is no benefit from chemotherapy up to a recurrence score of 25. And therefore, whether your recurrence score is 1, 10, 15, 20, or 25, you're not going to see a differential effect of chemotherapy because it's not doing anything to the patients. And I'd be really interested to kind of have a mini debate about that with Stephen. Before we move to that point, I'd just like to show you what actually happened. And the lady herself had actually had some problems with a wound infection, and time was ticking on. She still had an open wound. She was very unkeen to have chemotherapy, and we decided that she would start tamoxifen and then add ovarian suppression and aromatase inhibitors sequentially. And just as a note, we're not currently offering adjuvant bisphosphonates to postmenopausal women because of COVID and the incremental value of the zoledronic acid infusions and the risks of bringing patients up to hospital. And I think, again, our discussions about chemotherapy are quite coloured by COVID in the UK at the moment, not because we lack the capacity to deliver the chemotherapy, but because of our concerns that if patients develop infective complications of treatment, they're likely to be sitting in casualty for very long periods of time before they get that magical first dose of antibiotics, and the risks of complicated neutropenia infections go up. And even in adjuvant breast cancer, we do still sadly lose patients to infections, and that's obviously a complete disaster. So to end my part of the consultation, what will change tomorrow and the practical implications of the RxPONDER trial. And these are quite interesting in that yesterday morning, first thing, we had a meeting of all the consultants in the cancer centre from all of the different tumour subtypes. And we have been looking very actively at ways to reduce the toxicity of the treatment because of the limitations on our ability to treat the complications because our hospitals are so full. And the organisation, so the host organisation without any NHS funding at risk, agreed to implement the results of RxPONDER and allow us to test patients with ER positive, HER2 negative, no positive disease. I was a little bit woolly about who we might test to avoid the risks associated with adjuvant chemotherapy during the current excruciating COVID prevalence in the UK, with ITUs up and down the country being overwhelmed with patients. So I'd like then to throw back into the discussion and invite Steve to comment in the first instance on our management of this patient.
Thank you, Mark. And maybe I'll comment, and then Julie, would you like to sort of moderate? I think there were a few questions that came through the chat. Yeah, it's just, so just to be clear, your patient was premenopausal, as you said, and she was on the upper end of the recurrence score based, so if you look at the RxPONDER, one would quote her that amount of difference of about 5 to 6% difference in IDFS. The difference in distant disease-free survival is smaller because not all of the events were distant events. But it is challenging, and I don't think we're going to know if ovarian suppression plus aromatase inhibition would equate to a similar sort of benefit. And I think that's going to be our challenge. I think those patients that really are not going to do chemo that I would absolutely do, as you have said, and particularly during this COVID situation, I think the risk of developing of morbidity and death is concerning. But I do think it's an unknown, and I think at least based on this study, it's not, at least my practice is to recommend chemo, but with all the caveats that there's some uncertainties. If we did this instead of chemo, could we come out at the finish line the same? At least the toxicities would be less. That we would know.
Thank you.
Julie?
Yes, actually, the first question from Dr. Al-Noman was really along these lines. As simple as this, would you today prescribe Oncotype DX for premenopausal patients?
So I can tell you in British Columbia and that we will be asking for public funding for Oncotype in our postmenopausals and not in our premenopausals. We feel that the magnitude of benefit, regardless of a score of up to 25, so whether it's 1 versus 25 or 1 node versus 3 nodes, at least from the data that we have so far, is similar in favor of chemo. And again, we work in a cost-restrained, public-funded environment. In postmenopausal, I do believe there's utility, and I would avoid significant use of chemotherapy in my postmenopausals up to 3 nodes. And again, I don't know where my threshold is, but it's somewhere around 30 to 31. But I think that's going to be something that we need to hopefully address in future trials if possible. But that's only my answer. I'd be interested to see what Mark's answer is.
I find it quite hard because our lady that I presented on very deliberately, first of all, chose the case because of the timing, and secondly, because of the uncertainty, because she was amenorrheic because of her progesterone-eluting coil. And I think the worry is that aged 49, if she was classified as premenopausal, then you're saying there's a big benefit from treatment. If you classify her as postmenopausal, there's no benefit from treatment. So say you had a patient who was 35 and was very worried about breast and ovarian cancer risk, not known to be a BRCA mutation carrier, but a horrible family history, had completed her family and had had her ovaries removed. She would be classified as postmenopausal. And you're saying by the simple fact of removing her ovaries, you're taking her from a group where there's a big advantage from chemotherapy to a group where there is no advantage from chemotherapy because it's a classification by menopausal status and not age. So I worry that, we can very easily, and we do it all the time in advanced disease, take premenopausal women and we make them postmenopausal because that suits our treatment aim. So I find that hard to explain. And the other thing that really resonates with me about this is that if there was an advantage from chemotherapy, everything we know about Oncotype and recurrence would suggest, and all of the curves that we see, all of the reports that we see, everything we've ever seen before suggests that as the Oncotype value goes up, you begin to see an advantage from chemotherapy. And you said that yourself in your talk, Stephen, 25 versus 26, they're probably still not going to benefit from chemotherapy. And if there is a benefit from chemotherapy with a recurrence score of 25 and below, based on the cytotoxic effect of chemotherapy, how come we are not seeing an increment based on recurrence score? Because every other study has shown that as the recurrence score goes up, the benefit from chemotherapy exists. And the only thing I can think of that tells you that it's something other than the cytotoxic effect is that there is no interaction, there is no predictive effect of the recurrence score to tell you that chemotherapy is helping. And that goes against every other study, every other piece of evidence, every other hypothesis that we've ever seen in this space. So I think it is very hard to explain it as a cytotoxic effect. Although, having said that, the magnitude is so great that, maybe it is, but we don't know how many people we pushed into the menopause with chemo.
Yeah, I think it's a really good point of just our struggles of trying to reconcile the data. And the beauty of this is that it isn't so black and white, and it does allow for great dialogue and debate and unfortunate consternation. At least the way I think about it is, I do think a breast cancer that develops in a premenopausal state is different than a breast cancer that develops in a postmenopausal state. There are genomic data to show differences in luminal B versus luminal A presentations, and that itself may reflect it's not just simply putting someone into menopause after they developed breast cancer, but what is the breast cancer that developed up until the time they were rendered menopausal. So those are two different things. In the TEC study, again, they started their LHRH and ovarian suppression or TAM and AI and TAM right up front, not if after they got chemo and remained in the premenopausal state. So I think there are a lot of different possibilities and hypotheses that we all struggle with. And what we clearly need is we need a study now in premenopausal of comparing with oncotype and comparing chemo to plus standard endocrine versus ovarian suppression plus endocrine to answer that question. And whether that gets done or not, I don't know, but we clearly, I think our patient population deserves to answer that question, because you and I can debate this, but I don't think there is a clear-cut answer, because the studies have not been powered to answer that question, and the subgroups are not large enough.
Yeah, and I think you bring into play again, actually, we're debating the premenopausal women that are a small proportion of the women in the study. And I think, we're behaving like medical oncologists. And I always say that if you run a meeting and you have a discussion amongst medical oncologists and you see a searingly positive study, we're always looking for the group where the treatment doesn't work. And if you see a really negative study, we're already looking for the group where the treatment does work. And I think what's massively important about RxPONDER is that most patients who develop breast cancer are postmenopausal. And this very definitively tells us that if you have a postmenopausal woman with 1 to 3 involved axillary lymph nodes and an oncotype score of 25 or less based on the data, and I completely agree with you about the cut point, they can safely be spared chemotherapy. And I think with what's going on in the relationship between age and COVID outcomes, that has allowed us to immediately enact this piece of science in our routine practice. And I think the debate about premenopausal, absolutely fascinating, but we mustn't lose sight of the postmenopausal message, which everybody agrees about. So there's nothing to talk about.
If I can ask, there are quite a few questions coming in the chat. So One question, we just talked about the postmenopausal patients. Were you surprised when you look at the data and realize 80% of the patients postmenopausal node positive have a recurrence score 0 to 25? Based on your practice and what you've done in the past, was it surprising to you?
Well, I think you just that's a good someone paid a lot of good attention to that and highlighted that. But you got to remember that a number of patients decided to take the recurrence score and run and not be randomized. Remember, over 1,000 patients did that. So I think there's a bit of a biased population to a more lower recurrence score, because those that had a score slightly higher than, let's say, 16 to 25, they might have decided not to get randomized. So this is not a real, true natural history population.
Yeah. We do see similar proportions when you look back at SEER or CLALID registries, which are real-world registries. I agree these are patients who are chosen to be tested. We see about the same 80% of patients with recurrence score 0 to 25 there for specifically
Yes, but not necessarily 0 to 15 though, right? If that's the question.
It's quite interesting trying to dig up, because I tried to find data that would support this, and there's some Californian data that's got a lot of women in it, where you can see that the younger you are, the more adverse both biological and oncotype features you get. So if you're younger, you're more likely to have a higher score. If you're younger, you're more likely to have an unfavorable intrinsic subtype. And interestingly, If you look, I don't know if people are familiar with it, but Alex Pratt presented data from the Mona Lisa studies, so it's metastatic disease, but they looked at intrinsic subtype as a predictive biomarker for the effect of CDK4/6 inhibitors. And you can see very clear differences in the numbers of luminal A, luminal B, and HER2 enriched cancers in the Mona Lisa 7 study that was a premenopausal study compared to the Mona Lisa 2 and 3 studies that were both postmenopausal studies. So, I mean, I agree with Stephen that people with premenopausal breast cancer clearly have, even within the ER positive group, a different distribution of intrinsic subtypes.
Mm-hmm. Let me bring this patient case here from Dr. Ghazal, who is referring to a 53-year-old lady, but still premenopausal. Imagine recurrence score 25 and 1 positive lymph nodes. What would you do with this patient? What would you recommend?
Well, I think, you just have to sort of align with the study. So this patient, despite her age, is premenopausal. We all have patients in the early to mid 50s that are still premenopausal. And I would quote her, based on this study, that chemotherapy appears to benefit IDFS by about 4%. 4 to 5%, and a 1% difference in survival, albeit the follow-up is still early. Again, this goes back to Mark's question. She's close to postmenopausal. What if we just, did ovarian ablation and whatnot? I think that's an option, but to me, my own personal, at this point in time, that's option B, not option A, based on what the data is available.
Mark, any comments from your perspective?
And I think you have to have the discussion with the patient. And I think people are different, and
right.
It's a difficult conversation because there isn't a right answer. And I think that, you often have to think that when you're in a consultation with a patient, she's like on that cusp. So if she was postmenopausal, it would be straightforward. If she had 10 involved lymph nodes, it would be straightforward. And again, one of the things that slightly vexes me about the language that's used in the Oncotype story is that we talk about low, we used to talk also about intermediate, and we talk about high scores. But I think we have to remember that these are all patients at the lower end of the risk spectrum. And we see modest advantages because it's not triple negative disease, it's not HER2 positive disease, it's ER positive disease. And we know that chemotherapy isn't the best treatment for that group. And the other, Stephen was talking about clinical trial designs, and maybe we should be also looking at, Oncotype recurrence score, premenopausal women. Would we get the same benefit from introducing CDK4/6 inhibitors into that space, which is going to be very controversial because the trials that we've got in the adjuvant setting are all over the place. But I think you've got to sit down with a patient and have the discussion. And some patients will say, I don't care what the gain is, I want the chemotherapy anyway. And some patients will say, Dr. Verrill, I don't want your filthy poisons. I'm going to take my chance. I think we have to involve the patients as partners in that decision making. What's important as you go in is you've got to have an idea about what you will advise. And I think that, unlike the UK system where we're called consultants and we give opinions, I think it's really important. We're there to offer advice and tell people what we think, but ultimately we've got to make shared decisions. And there is no wrong or no right answer. All of these people are doing pretty well. They're not triple negative. They're not heavily node positive ER, HER2 positive patients. The benefits, even in the premenopausal setting, while clear, are still quite marginal. And I think we've really got to remember that. And the other thing I think that comes back to the point Stephen was making is that probably the morbidity of giving ovarian suppression and an aromatase inhibitor to a very young woman is probably greater than the morbidity of chemo because it lasts for years rather than a short, sharp shock.
Yep, good point. Julie, can I just go ahead?
Yes, Stephen?
I just wanted to, I don't know if we only have 5 more minutes. I don't know if this is going to end already on time, but just to very quickly answer as many questions as we can. We have not seen any subgroup analysis based on histological subtype, lobular versus ductal. That hopefully will come out in a future analysis. But if you have a lobular with a recurrence score in the range that we've discussed, then one can assume that that's what it is in terms of magnitude of difference. If you have a low ER, it's unlikely you're going to have a low recurrence score. Usually the low ERs of 10% expression or less, in my experience, they more than not are basal-like in if you do subgroup subtyping, intrinsic subtyping, but they're likely going to have a high recurrence score because ER drives a lot of the recurrence score. It's true that sentinel node versus actually node dissection was stratification, and in the forest plots, there does not appear to be a difference. I think the difference here is that if you have 3 of 3 nodes, your risk is higher, so your absolute benefit may be higher. Again, they were all grouped together, the 2 to 3 nodes. The hazard ratios would quote still a significant benefit. And then I just want to end by saying that I completely agree with Mark that this provides more precision in terms of what the benefit may be or lack of benefit. But at the end of the day, it is a joint discussion between us and the patients. And what some patients' threshold for benefit is maybe 10%, in which case maybe you're not going to get that from any of this. And some of it may be 1 or 2%, in which case in a premenopausal, you don't need the oncotype because the benefit is going to be more than that. So yes, it does matter in terms of the subjective discussion and really the relationship you have with your patient and their wish for what the difference magnitude they want to see.
Thanks, Stephen, for addressing the questions indeed. And I may read as well the comment from Dr. Al-Sagir, who actually, exactly to your point, say many of us feel that oncotype remains helpful for premenopausal patients, for patients in their late 40s, where we can safely rely on hormonal therapy and OFS rather than chemotherapy. So that exemplifies what you were saying. There are beliefs, there are a lot of patient preference coming into play here. So it's interesting to see that there are very different perspectives from that point of view. I think, we have a lot of discussion on the results for premenopausal patients where, of course, this trial doesn't address all the questions because of the fact that not many patients had OFS. Would you agree to conclude, though, that if we look, as Mark was saying earlier, at the postmenopausal patients, these are practice-changing results for our practice? With a great clarity that we didn't have before that will help us tremendously for our patients.
I completely agree. I mean, I just saw a 55-year-old with grade 2 ER PR 8 out of 8 and 3 nodes. And 6 months ago, I would have recommended chemotherapy. Today, I would ask for the oncotype. And if it was less than 25, I would relay the results and not recommend chemotherapy if it was score of less than 25. So, and that's that itself can substantially change the lifelong morbidity of a patient, of avoiding chemotherapy in a postmenopausal patient.
Yeah, and I would echo that. And I think, yeah, the discussions about the people where we don't have the clear answer, but the majority of patients with breast cancer are postmenopausal women. And we now know that those with limited axillary lymph node involvement do not need chemotherapy. And that is an incredibly important, and it is an immediately practice-changing conclusion from a clinical study. And I think that I feel very lucky that, as I say, because of the challenging times with COVID, the organization in which I work has said, yep, we agree, we're going to let you do that now. And the people coming through the door are going to get the test, and many of them are going to avoid chemotherapy and all the baggage that comes with it. So the discussion is about the uncertainty, but the certainty is of, it's a game changer for that group of women.
Great, thank you very much. I think these are great conclusions. Excellent discussion tonight. I would like to thank both of you very sincerely on behalf of Exact Sciences, and importantly for our audience for addressing their questions as well. And thank you very much for the rich discussion. Wish you a nice evening and a good day.